Good afternoon, everyone. A warm welcome from the GEM Televersity. We are going live from the Medical Gastroenterology OT suite from GEM Hospitals. We will be telecasting 2 live cases today. The first one will be live, and the second one will be a virtual live, which is a recorded case. Let's introduce you, the team. We'll have on the scope end Dr. Sridhar, the medical gastroenterologist who will be performing the ERCP. The anesthesia, the team led by Dr. Shivmurugan sir, and we'll have at the endoscopy technician end Mrs. Chitra and Mrs. Albi and Mrs. Anju, and Mr. Ranjit at the CM from the radiology clinic. Let's go forward with the case. I'll first introduce to the case. We have a 50-year-old gentleman who has come with obstructive jaundice and pain abdomen. Patient has a past history of laparoscopic cholecystectomy done 2 years back. And he has done an MRCP imaging, which has showed 6 mm distal CBD calculi with a dilated common hepatic duct and IHPR, and will be going forward for ERCP of the same case. Thank you.
Here we are. Prone position. Patient, we are always doing the patient in supine position. That is our protocol here because we do a lot more combined cases back here in GEM with the combined laparoscopic cholecystectomy with ERCP in the same setting. So conventionally, ERCP is done usually in prone position, most of the centers across our country and even abroad. But here, since it's a easy access to do it in the same position, in the same sitting for both the combined procedures, that's what we usually practice in. You can see the patient in the prone position, supine position here. And the team has already been introduced. We'll get over to the case. You will get the stream of both the, we have selected a basic case like this to make sure that the basics are covered, and this is to facilitate the right steps to be done throughout the procedure. Before we touch the case, whatever has been elaborated by Dr. Anaga, this is a small CBD stone at the distal CBD, and especially a post-laparoscopic cholecystectomy has been done for this patient. The first precaution we should do is to hydrate the patient well and to make sure we give a rectal diclofenac, which has been done to prevent a post-ERCP pancreatitis. So even before intubating, make sure these things are covered, and let's proceed with the case. The AC potutu jella. So we are using Fuji system here. If you can see here, this is a 6000 series scope. Can you see the system here? This is a Fuji system 6000 series, and the scope which we use here is a 580 XT scope. This is a 580 XT scope from Fuji, and this is the 6000 series processor which we are using for the ERCP case today. The most important part, hope you're seeing my screen. So the most important part of the ERCP, especially in supine position, will be to make sure we reach the D2 segment in single shot without inflating the stomach too much. The more you inflate, and you can see the gush of golden bile coming, which itself could indicate it could be a passed out stone by now. By the time you go inside, you can see the amount of bile here. Please make sure the stomach is not over distended and you don't go in a long loop. As you go across the antrum, you will see the pylorus here. I'll just distend and show you. You can see the pylorus right here. And as you cross this, you'll see a sun setting sign. You need to go to a point where it's a sun setting appearance, where you slide across the pylorus without much resistance. And since it's a sidewing scope, you're going to see only the 12 o'clock position of the pylorus, not the entire pylorus. If you're seeing the pylorus like this and you're entering, you basically means your sidewing scope is looking much more tangentially, and it will traumatize the patient both in the stomach as well as in the duodenum. So the first step is to make sure you go in a sun setting appearance, and you have entered the D1 duodenal bulb here. And you can clearly see, as you turn right, as you curve the scope right, and ERCP is to be performed with your entire body. You cannot be stiff. And as you glide the scope across D1, D2 junction and you enter the D2, you can see the duodenal folds very well. You can see the amount of bile with the bubbles very, very clear. What you see here, don't be premature to be fooled whether it's the major papilla. Make sure you shorten the scope and just try to look for the frenulum. The papilla always has a frenulum beneath, and as you trace the frenulum, you can see the papilla here. We'll be using Boston Scientific sphincterotome. This is a Boston Scientific sphincterotome which we'll be using, and the wire we'll be using is O35. O35 from Olympus, which is a VisiGlide. That is a guide wire which we have used. See, our technician has left the grip of the scope, and we are back looking at the fundus of the stomach. You left the scope. Okay. So we are going again, and we are going again across the pylorus into the D2. I'll request Anju to stay awake for some time. Maybe awake. Okay. Okay. So the first step of ERCP will be to identify the papilla. Like after you've gone to the D1, D2 junction, you've reached the D2, make sure your papilla is visible and it is in the upper right quadrant of your screen. If you divide the screen into 4 quadrants, try to keep it in the upper right quadrant of your monitor. So this is where it is. If you keep it more central or towards the left, there is always a chance your accessories might not come in the right way. Neither go too close nor be too away. Most important step, don't see the papilla from above. If you see the papilla from above, all your accessories won't go in the right direction. So be in phase, see the papilla, visualize the papilla right in front, and try to keep as much as in the upper right quadrant as much as possible. Neither too close nor too tight. And what you see, what you see here is the elevator, which is moving freely. And as you bring out, just want to show you the sphincterotome in the direction at which it comes out. So when it comes to the beginners of ERCP, you need to understand the sphincterotome will take a tangential course right from this part of the screen across the screen into that way. And the sphincterotome is an instrument which can change its axis also. You can request your technician to bow and unbow. Can you please bow and unbow? And unbow again. So you can ask your technician to do this to make sure your axis is much more established freely. So in this case, you don't really need so much of bowing here. The right position is mandatory here. First step is to identify the papillary orifice. And the papillary orifice, you can see it bulging, and you can see the opening here, which is here, and you can see a smaller opening here. So basically, a human papilla has both the bile duct and the CBD and the PD opening up into a common papilla, right? So we need to be really sure that the cannulation is towards the CBD, right? So we are still maintaining an upper quadrant with the right side skew of the papilla. We are made sure the sphincterotome is neither too away or too close. And we are trying to keep and cannulate in such a way the upper 11 o'clock of the papilla is touched, as you can see here, right? And when you cannulate here, make sure too much of pressure is not put. If you do put too much of pressure, there is very well chances that it might take a straighter course and it might go into the PD, which is not desirable for most of our cases. And don't push the sphincterotome. Just stay there. Ask your technician to put a guide wire across to see the movement of the wire. Can you pass the wire? If you find a resistance or a deformation at the level of papilla, hold back. Always you can get back to the retry again and go back again, and you can again try to cannulate, right? And the access is much more important than pushing the sphincterotome blindly, right? So you can ask the technician to bow a bit. As you bow, you can see the papilla and the sphincterotome taking a tangential course towards the 11 o'clock, right? So you can see a bit tinge of bile at the tip of the sphincterotome also. Pay close attention to tiny details and try to use the guide wire maximum. Try to push the guide wire, please. There is still some resistance. You can see the sphincterotome moving. I'm going a bit closer. The axis is not happy. I'm removing the sphincterotome. I'm removing the wire எடுத்துருங்க. So just changing the direction a bit, trying the same axis a bit, trying to get a bit closer and bowing a bit. Bow பண்ணுங்க. Still more. Still more. Okay. I'm pushing the sphincterotome downwards so that I get a 11 o'clock axis. Put the wire, please. I'm changing the right left wheel to facilitate. Can you put? Try. Not working. Okay. Okay. I'm removing unbow, please. I'll change the direction. I'll go towards a more likely a 12 o'clock question. Basics first. Let's not rush towards things. We cannulate. We not push. We make sure the sphincterotome is bowed. Bow பண்ணுங்க. Bow, please. Change the axis. Make sure you are in line with the papilla. Wire. Wire. You find a resistance, your technician is giving a feedback, respect it. You want to check with your fluoroscopy, please do. Can you check with the fluoro, please? Yeah. You can see the hockey stick appearance of the side wing scope. You can see the tip of the sphincter cannulated, and you can see a wire little above the papilla, but it is straight in line. You can see the previous laparoscopic cholecystectomy clips there. Can we have some silence? Wire putting? Put some wire. Let's see how it goes. And you can fluoro, please. Fluoro. Okay. We'll remove the wire a bit. Yeah. Screen. Okay. Push the wire inside. Push the wire, please. Okay. Okay. Remove the wire. Okay. I'm glad they didn't cannulate. I like cutting the sphincter more than meddling with it more than 5 minutes. Our cutoff here is, at least in our unit, is 3 attempts. 5 minutes is where we stop and we go for a pre-cut sphincterotomy. That is where we lied. That is where we stop the line in meddling with the sphincter. The more time you take for a cannulation, the more the chances of post-ERCP pancreatitis. So worthwhile to use a pre-cut sphincterotomy much earlier on. And in this case, you can, when they give the needle knife sphincterotomy with the guide wire, you can see the small tiny diverticulum developing in this patient, which is above the papilla here in the screen. So we are using a Cook needle knife. We are loading it with our 035 needle. And for a change, I have practiced myself towards using a pre-cut access sphincterotomy rather than a regular access sphincterotomy, which is cut from below. Needle out. The difference between a pre-cut access sphincterotomy and a conventional pre-cut is the Access sphincterotomy is like a fistulotomy. You don't de-roof the papilla, but rather than that, you just make an access over the bulge of the papilla. Needle out. This is the bulge which you notice, and this is exactly where we are going to cut for a access fistulotomy instead of a conventional cut from below upwards. And as you cut the pre-cut axis, you will first do it layer by layer without rushing. And the most important structure you need to notice is the sphincter, which is tuna pink colored. And as you pay more attention to it, you will notice this is the tuna pink you need to observe on. As you get closer, you'll appreciate the sphincter and the tuna pink appearance of the bile duct. And you can see sometimes a gush of bile. Be layer by layer and do it patiently much more. Needle in. Hold the scope firmer, please. Okay. When you're not able to visualize, place much attention into the sphincteric contraction and relaxation. And if you're not able to visualize, you can ask your technician to flush it a bit. Flush panning. Stop. The point of doing an axis sphincterotomy, it is layer by layer and much more defined than a crude cut from below. Needle out. You can see a little bit of a bulge which is appearing and disappearing. Since this could be still a passed out stone, we are dealing literally with a normal duct. And the device, the monopolar device which we are using is an RB cautery device which is attached to the needle knife. Wash. The wattage is endocut 1 with 60 watts and effect 2. Okay, stop. We are not seeing a gush of bile. So basically it means it's not an obstructed system, but you can see the sphincteric contraction and relaxation much more clearer. Okay. We'll try with the wire out, and I think we are in track with that. Can you keep the wire out, please? Can it? Resistance is noted. No, it could be still a false track. We are not rushing in. We'll wash this cut again. Please cut. Please wash. Okay. Can you keep the wire out? Can let? The wire is still has a resistance. We are bringing out. We have Dr. Anaha here. You want to add some points? You need to come. Where is the mic? Here. You want to add? You can add. Oh. Just ask something. We'll answer.
We hope the people are still online and awake. So we are continuing to attempt for the cannulation as of now. As you all saw, we had a difficulty while cannulating through the major papilla. We have tried the access through our fistulotomy now. As sir would have already mentioned to you, mostly we are attempting in a normal caliber CBD with the background of a passed out CBD calculi. So whenever the CBD calibers are normal, the cannulation itself becomes a bit difficult because we have a collapsed biliary system which is already decompressed as the calculi is passed out. And in the background, we had already mentioned to you that it is a case of post cholecystectomy where the gallbladder is absent for the patient. If you can just focus on the cholangiogram image, we can see show you the CM image. As sir mentioned to you, the hockey stick appearance of the scope, we were not able to show you the visual then. I hope it's clear to you. We can see the cholangiogram, the CM image as of now, where we see a hockey stick position of our duodenoscope. And
You can see the wire getting into the PD axis. You can tell.
okay. See, as we can see the cholangiogram image now, it shows that the wire has proceeded towards the pancreatic duct, which was inadvertent. And how do you identify the wire going towards the CBD or the PD? What we can see is, can you just show the previous image, Siam? Okay. See, due to technical difficulties, we'll just explain with this image as we see now. Basically, when you have the guide wire crossing your towards your spine section, you can see the spine in your CM image, and when it crosses horizontally, when it is crossing through the spine, it means the direction is more towards the pancreatic duct. Ideally, in a CBD, we expect a more vertical course of the guide wire, which has not happened in the case so far now. So let's get back to the main endoscopy screen. So what our technician now is trying is to wash the papilla. We'll try to locate if we can see any tinge of bile anywhere, which makes the access more easy. Okay. So what we are attempting now is to extend the cut a bit more, which would facilitate the cannulation even more easier. I hope I'm audible. Anybody having any queries can raise in the chat box. We'll attend to it. So what sir is trying to do now is to extend the pre-cut a bit more. So we are trying to go more deeper with the cuts. Yes. If you can take a bit more closer view towards the 12 o'clock, we can see a small tinge of bile, yellowish shade, which might be the axis we are trying for now. We are washing the area. Yeah. As you notice, we can see a more clearer bile tinge now, more towards the 12 o'clock. Hope you are into the system. You can focus the cholangiogram now. See, we can see the CM image now, as we have already mentioned. Now the wire has taken more over of a vertical route. We can see the cholangiogram image now, where our guide wire has entered into the biliary system, uh, which is added on by the evidence of the fresh flow of bile that we see in the scope image.
You are not covered.
It's okay. I am standing behind it. So just yeah. Uh, please, please have a closer look at the cholangiogram. We are injecting the contrast now.
What contrast
Yeah,
are you using?
we are using a iohexol contrast, which is a very low osmolarity contrast. We are using more the iohexol contrast, which is a very low osmolarity and a lesser mucosal irritant. Very lesser chance of having cholangitis. We tend to use that. You can have a closer look with the cholangiogram. See, yeah. Sure. So, yes, in the image, we can see a keyless stone. We can see the guide wire mostly in the right anterior hepatic system, and we can see a dilated CBD. So basically, the size of the CBD we compare with the scope. We use a standard duodenoscope, which is around 12 mm diameter. So the cholangiogram shows a CBD and the CHT of a similar size. So hopefully, we have a dilated biliary system where the common bile duct would be around 10 to 11 in size, and we can notice there is a small filling defect possibly in the distal CBD. You can have
the tapering of the
yes,
CBD.
yes,
Just highlight
yes.
because
Uh,
CBD is dilated and there is a smooth tapering of the distal.
can you have a closer view of the cholangiogram image if possible?
And the CM image is zoom பண்ணி change.
So, what we can notice, like an added on screen, on the screen, fluoroscope.
Fluoroscope. Fluoroscopy zoom பண்ணு. இல்ல அந்த மிரர் வருதா?
உங்களுக்கு so-
Can you see the cursor? You can show the cursor.
Uh,
Cursor கீழே காட்டுங்க, கீழே காட்டுங்க, கீழே கீழே.
அந்த ஸ்கோப் சைடு டிப் சைடு
கோப்போட tip காட்டுங்க.
If you take a closer look at the cholangiogram, what we are seeing is a dilated biliary system. And if you take a look at the distal tip, the tip that is closer to our scope tip, we can see a smooth tapering. Where you see the CBD is tapering smoothly, we are not noticing any abrupt cutoff. It's a small tapering cutoff with a small possible distal filling defect just above the tip. We hope our camera zooms in and you're having a proper visual of the same.
Despite the cut, there is traces of contrast.
Yes. The tapering, more evidence to that, we can see that even after we have trolled out, the cut is extended, we can still see that the contrast is not fully drained off. We still see stasis inside the CBD. So there is a possibility of an underlying stricture also, which is evidenced by both our cholangiogram and the stasis of the contrast. So what we are next planning to do is to introduce the balloon. So sister is loading in a Boston balloon. So we are just waiting on as the balloon is taking the route through the channel of the
What do you
scope.
think of the cystic duct in this case? The cystic duct, how do you see? Is it still patent? What could be
Yes,
the
sir.
reason for this stone being residual?
We can see the clips in the cholangiogram image, which is actually put at the cystic duct clips we can see post cholecystectomy. The tortuous image that you see is suggestive of the cystic duct. We can see that even the cystic duct is mildly dilated.
And this could be a reason where the stones could still be left over, the residual CBD stone. It could not have been a CBD stone, could have been a
Cystic duct stone that would have fell off to the later on.
Because of the tiny little stricture or the periamplar divertic,
They are remnant.
the stone wouldn't have come out.
Would have
It's such a tiny stone, possibly 3 to 4 mm.
3 to 4 mm stone. As per the MRCP evidence, we have a 5 to 6 mm stone, but our cholangiogram more precisely say it should be a bit more smaller stone.
So as you can say, as we inject, as we inflate the balloon to
Yes.
2.5.
Yes. So our next procedure will be inflating the Boston extractor balloon. So the technician is inflating the balloon. We can see the first one, the stone being delivered now. You can see a black pigmented stone which had come out, which actually justifies the small filling defect that we saw in the cholangiogram and the fluoro image. The balloon has been deflated. We are again advancing the balloon inside. We will be proceeding with the check cholangiogram once the biliary system is cleared. The endoscopist will have a feeling of clearance of the CBD as the balloon moves inside and out. When we have a residual stone, mostly we'll feel a resistance while we navigate the balloon above. So we are
Proceeding with the cholangiogram.
we are proceeding with the check cholangiogram. As you notice, the baseline was a clear cholangiogram where the contrast has drained. Now we are re-injecting the contrast. We still can see a dilated biliary system, but with no obvious filling defect till the mid CBD. We are proceeding even further. The balloon has come out. Some more.
Trace on possible filling defect.
We have a small linear filling defect that we saw towards the distal CBD where we had just above the suspected stricture. So we are going towards another trawl to possibly seek for the clearance. Where the technician here is again injecting 2.5 cc in the extractor balloon. We are again trawling out. A mild resistance, possibly second to the underlying stricture, but the balloon was freely coming out. We have inflated a 2.5 cc balloon. If you take a look at the cholangiogram, we can see the marker which actually shows the position of the balloon. If you see, if you see in the cholangiogram, we can see a small, tiny circular structure, which is a a filling defect we call it, but can be a air bubble, which is an artifact. Basically, how do you differentiate a stone or an artifact? Is a stone remains stable, it does not change its position, whereas a air bubble tends to float, it changes position, it pass away, and with a more troll or inflation, it basically come out. When we continuously look into another screen of the cholangiogram, we can see that bubble is no more there. So mostly what we saw was an artifact or an air bubble.
Should we stent this case or we should not stent this case? What will be the opinion across the? We'll ask the.
If the people are online, we would like to have your opinion also on the same. We have cleared the CBD as you had would have already seen it. We have a dilated biliary system, but the contrast was freely draining. The balloon was freely coming. The stones are out. We have a clear CBD now. So, what do you do now? Do you want to stent the biliary system or not?
What will be the opinion of the?
So, we'd like to know what is the opinion of the people who are watching.
What will you do?
I would like to stent it
Why?
because there was
There
an
are good indications where
that
we
we
should
have a stricture below.
possible that.
We have some contrast into the IHPR. So in that both way, we can have a follow.
It's a stricture which will indicate us to do a
Stenting
stenting
rather than a calculate.
the calculation. And since it's a post polycystemic status, worthwhile to because if there is no stricture, we could have actually avoided.
If you see the endoscopy screen,
This is the either zoom பண்ணி அந்த this is the same.
we'll now just zoom you the stents we are using for the biliary stenting. So what we are zooming out now is a double pigtail biliary stent, which is of 5 French in diameter and 5 centimeter, 7 French in diameter and 7 French in length. So if you see to the endoscopy screen, we have started loading the stent. If you see, you can see a black marker. Basically, in a double pigtail stent, we'll have 2 markers, one just below the first pigtail and another one proximal to the second pigtail. The black marker has gone inside screen. Yeah. So yeah. What you're seeing now is the second black marker, which means a good amount of stent had gone inside the duct. And we can see the pores at the end, at the distal tip of the stent, which actually shows how the bile drains through it. Having a closer look, we can see that the bile is coming through the stent which we have already deployed.
This patient had LFT changes,
Yes, sir.
but never jaundiced.
Never jaundiced.
Correct. So the stricture could have been a reason where it was not the stone blocking the whole scenario, but rather than the stricture and a small stone getting clogged, unable to pass. But the bile is flowing freely.
That partial stricture would have been also the reason we saw a lot of bile in the stomach when we went inside.
True.
Because if it was an acutely blocked stone, we would not
We
have
will not
seen
have seen
this
so
much
much
of bile when we
And the chronically obstructed bile will not look such a golden
yellow bile.
yellow bile. So that is where we stop
It
here.
does not. It looks like a gradually and chronically obstructed system.
And that too, a small dimple noted on either side of the papilla. He might have just started, and most of the time, even in elderly, the periampullary diverticulum itself can cause a traction under mild stricture, which can itself cause an obstruction under non-obstructive stone. Can we have the final screen to check the position of the stent? Yeah, you can explain.
So in the cholangiogram, if you take a look, since we have withdrawn the scope, we have lost the hockey stick position. We are just seeing the stent beneath. I hope the stent is clear. You can see the distal pigtail in the lumen. We'll have the proximal pigtail even more above. Can we have a fluoro bit above? Yeah. So possibly with the anatomy, we can say the stent is mostly extending toward the right anterior hepatic duct. We can see the distal tip inside the lumen. So if you're just to speak about the cholangiogram now, we can see a small amount of residual contrast in the cystic duct. we have a small amount of residual contrast in the cystic duct, which is identified by a nearby clip, that is post cholecystectomy clip. We can see the proximal tip of her stent, which has passed beyond it. So we would have mostly crossed the common hepatic duct and entered into the IHPR, and we have the distal tip straight deployed into the lumen. So yeah. Now we'll have a comparison of the two images. The one would be the cholangiogram image when the stone was in situ. The another one is after the biliary clearance when the stent is in situ. Uh, I hope the video team can zoom into the images.
14. 14 is the correct. Okay.
Yes. If you
can go closer.
If you have a closer look of the cholangiogram that is on our left hand side, we can see a dilated biliary system. Our guide wire is into the biliary tract. We can see a distal filling defect. If you see, it's around a few below the scope, where the scope is taking a turn. Just below that, you can see, I can point, hopefully I can see a small filling defect over here. This is possibly the stone which we have rolled out. And towards the end, one more, yeah, towards the end, we can see a small tapering, which is not much evident in this image. And the tapering will come.
17, 18. 18 or 17. Correct.
Yeah.
Correct.
Yes. Yes. Here in this image, you can see how the CBD has tapered itself. You can see a CBD coming straightly and it's actually tapering towards the end. Basically, when you have a CBD without a stricture, we actually have a free end, where here you can see a gradual tapering that have started a few above and it has tapered and end like this. So as sir would had already informed to you, explained to you, it is because we have a residual CBD stricture, the reason by which the stone has not passed out, and hopefully the stone might have been inside the cystic duct, which has then fell into the CBD, and the drainage is not facilitated because there was an expected stricture over there. As in the procedure, now we have cannulated, we have cut through the sphincterotome, the stricture has been released, we had a free flow of bile as well as the contrast. In the check image, we can see the image on the right side, you can see there is no residual contrast in the image. There is a stent in the biliary system. In the scopy screen, you would have seen how the bile has been freely flowing. You have a cleared and decompressed system as of now. Now the follow-up we'll do after a few weeks. We'll see how freely the bile is flowing, and if the patient is asymptomatic, a normal liver function with the imaging suggestive of no much changes, we'll possibly plan for a stent removal on the follow-up basis.
Thank you, Dr. Anaga. Thank the entire team, the anesthesia team, the technician team led by Mrs. Chitra, the radiology team, Ranjit, and the whole AV team behind this live telecast. This is one of our few lives which we do from the endoscopic suites. So, sorry if there was any shortcomings. We'll proceed on to the virtual live, which is an unedited video of an ERCP, which you could be seeing in a short while, in a moment. Till we are ready with the second case, we'll have some Q&A. Anything from the chat box, we'll be happy to answer. Post-op follow-up for this patient will be, since we had an inadvertent once PD cannulation despite a pre-cut sphincterotomy, we'll be watchful of the post-ERCP pancreatitis. But we have taken care of those right in the beginning by giving the rectal diclofenac or indomethacin. In this case, we have kept a Zonac suppository of 100 mg and we have given adequate fluids. The creatinine status was monitored before, so every parameter has been taken care of, and it was a single entry, it was a guide wire entry, so the risk of post ARCP pancreatitis is minimal. Post this is an immediate follow-up. Post follow-up after stent removal, we'll be still watchful of the biliary stricture, whether it's evolving further, whether it's causing an LFT change in future. In that case, we need to really dig into the other causes of biliary stricture also, which most important, males are developing an IgG4 related pancreatobiliopathy, which is a very important DD, which we should not miss out. We cannot blame just on the small diverticulum which we have, and this has to be followed up in future, because what we see is a dilated CBD with a smooth tapering distal CBD. So this is a case which we will have to follow up in future also. Any further questions? அது ரெடி பண்ணாருங்க அந்த இது stent. Stent can be removed in 6 weeks. See, ideally, if it's a tight stricture, we would have actually put up two or more stents in this patient, plastic stents, to make sure these are dilated. If it's been a tight stricture, we would have actually, even there are scenarios where we have chronic pancreatitis, we have put metal stems also, which is a fully covered stems and removable. So that is also possible in these, even in benign biliary strictures. This stent will be removed in 6 weeks' time to make sure we give adequate time for the whole area to heal and to make sure the stricture also is palliated. Any further questions? Yeah. Thank you, Pasupati brother, Alagar brother, and the whole team. Thank you. 5 minutes, we'll be ready with the virtual live case.